I'd like to invite Dr. Charles Kassardjian to speak about the neuromuscular landscape in the GTA. Dr. Kassardjian is a neurologist with clinical focus in the area, I'm going to mispronounce this, peripheral neurological diseases and neurophysiology, with a special interest in genetic myopathies such as FSHD. He's an assistant prof at the University of Toronto in the Department of Medicine, and his research and educational interests are in the area of quality improvement and patient safety. So
my name is Charles Kassardjian. I'm a neurologist here. I work downtown at St. Mike's in Toronto. First of all, I want to say thank you for inviting me. It's really a privilege to be here to talk about this today and to hear from everybody in the room today, experts and companies and patients, etc. And I'm privileged to look after patients with muscle diseases, including FSHD. It's really it is a privilege to do this and to help people in their journey. I'm going to be talking, the talk is a little different maybe than what the title implies. I'm going to switch gears a little bit and talk a bit more about the clinical aspect first, and then a little bit about the landscape in Toronto, because as you'll see there, that's a moving target and something that I think we need to work much more on for FSH, but also other types of muscle diseases and muscular dystrophies in general. So here are my disclosures. I don't have any that are relevant to today's talk. And we're going to talk a little bit about the clinical features. As Dr. Lockmuller mentioned, this is probably something that you guys are even more familiar with than us as physicians, but we're going to talk a little bit about that, a little bit about the management and the clinical care, and to touch on that landscape that I mentioned. So FSH is one of the most common genetic muscle diseases that we see. You might see it listed as number 2 or something like that in different publications or places. So we do see it's quite often something that we get referred in the neuromuscular clinic. And the age range is very wide. You're going to hear from Dr. Gonorowski afterwards about the pediatric aspect of it, but the age range can be very wide from childhood, and we diagnose people with new diagnoses in their 60s, even the 70s in some cases. So it has a very, very wide age range. And that's one of the things, that's difficult with it because of the heterogeneity, the difference in the way it presents, even within the same family. People can go misdiagnosed or undiagnosed for a very long period of time. So what's in a name? When we talk to the residents, sometimes I say that you get a lot of the features just by thinking of the different aspects of the acronym itself. And the F, of course, stands for the facial weakness. So folks can have the incomplete eye closure, for instance, difficulty puckering or drinking through a straw, for instance, a horizontal smile when they try to smile. And this is something that will come up later this morning in my talk as well, about how that impacts people emotionally and socially as well in terms of that smile. The S refers to scapular weakness and scapular winging. Folks can have atrophy of the pectoral muscles as well. And other features that we look for on examination that we teach our trainees about on examination that you can see in these pictures here, the scapular winging, what we call a hump, a triple hump sign, where because of the anatomy and the way the atrophy occurs in the arm, you get these characteristic kind of appearances that can help us in our diagnosis. And this is what we teach our trainees so that we try to improve that diagnostic yield and improve the ability to recognize this condition early and proceed with the appropriate testing early. The H is the humeral weakness. So the humerus is the bone here in your arm that's from the shoulder to the elbow, basically the arm bone here. And so the muscles there are the biceps in the front that flexes your arm and the triceps in the back that extends your arm. And so those two muscles tend to be preferentially weak as well, as you can see in this picture here with the weakness there and the relative preservation of the forearm muscle, which is kind of also a quite characteristic sort of appearance there. What's not in the name, though, because there are many missing features there in the name that also can be helpful diagnostically if someone doesn't have the classic picture, the classic features, which can be absent in some individuals. Often people will have foot drop, so that's the difficulty bringing the foot up at the ankle. And so they may walk with a kind of a slapping gait or might even trip on their feet, which can be quite potentially harmful. Trunk muscles are often weak, and you can see in this picture here, the abdomen is a little bit protuberant there in the photo, and that's because the lower abdominal muscles can be quite weak, causing that protuberance and sometimes over what we call a hyperlordotic position, so walking kind of in a waddling type of position. And the weakness does progress and can affect other muscles over time. These are sort of the classic initial features that help us make that diagnosis and clue us into the diagnosis early, but over time, many other muscle groups can be affected. Here's a video just of I don't know if the video actually, yeah. Because of that lower abdominal weakness, one of the signs we, again, teach our trainees to look for is something called a BVOR sign, where the lower abdominal muscles are preferentially affected, the ones below your belly button, as opposed to the ones above your belly button. If you were to do a crunch in someone without FSHD, your belly button shouldn't move because both parts contract. But someone with FSHD and some other conditions as well, the upper ones contract, but the lower ones don't contract as much. And so we do look for this in clinic, and with permission, this is one of the patients. So you can see the belly button there. When he tries to do a crunch, the belly button kind of gets sucked upwards because those upper muscles contract and the lower ones don't. And then let's finish off the name. We'll stick with the name here. The whole muscular dystrophy thing sometimes can be a little bit confusing. Muscular dystrophies are a group of mainly genetic muscle diseases that are progressive. And the muscle damage that occurs over time causes degeneration of muscle fibers. And that degeneration over time, if it goes unchecked, muscle fibers become replaced by fat and connective tissue, which is generally an irreversible process. And so, muscle biopsy was a way to diagnose muscular dystrophy because you would see those changes on the muscle biopsy. And in many cases, we still need a muscle biopsy for some conditions, but not so much for FSHD anymore because of the availability of genetic testing now. When we see that classic presentation, we go straight to genetics. We don't need to do a muscle biopsy. The presentation can be very variable, and this leads to that sort of delay and difficulty in diagnosing. Not everybody has all those things that we talked about. As many people in the room probably know, we don't necessarily have all those features. And so the presentations can be very atypical, and we have to be very astute to some of these more subtle things if we want to come up with the diagnosis in those individuals, and that can lead to delays. Another feature that many people in the room probably are aware of is it can be very asymmetric, which is different from many of the other genetic muscle diseases that we see. The weakness can be slowly progressive, as Dr. Lockmuller mentioned, but there are these periods where folks can experience more sudden changes in their worsening and other periods of plateau. And generally speaking, life expectancy is not thought to be reduced. In most muscle diseases, we talk about extramuscular manifestations. You might hear that said, and there aren't as many as in maybe some other conditions, but there are a few things that we screen for, like issues with the eyes, where the blood vessels are not quite normal, leading to things that can be secreted in the retina and can lead to vision issues. Folks can have hearing loss and musculoskeletal problems in the chest that can lead to some difficulties with breathing, for instance. And the heart is generally not affected, with rare exceptions. So in terms of management, so we're going to hear a lot about treatments, I think, later on, so I'm not going to touch on those at all in terms of the new treatment trials and things coming out. But right now, in terms of what's available to us in clinic, it's really more of the supportive aspect. So we focus on monitoring. So what are some of those complications? So we might do respiratory monitoring to ensure that there isn't that restriction of the chest. We might do hearing or ophthalmological screening. I do want to mention the importance of our physiotherapy and occupational therapy colleagues, who are really crucial components. And this is part of the issue with the landscape in Toronto that I'm going to address afterwards. This is a very important part of things that I think has been somewhat neglected, particularly in Toronto to this point. But there is evidence for exercise and rehabilitation. I think you'll hear about that later too, including low to moderate aerobic training, which can improve strength. It can also improve fatigue, which is a major issue in people with FSHD. Just simple things, walking, stationary bicycle, swimming, even some mild resistance training as well. And an assessment with a physiotherapist is always a good idea. This is an example of something that, in the literature, they'll sometimes discuss, short periods, 10 to 30 minutes of some sort of exercise, such as cycling a few times a week. Some resistance training, just step-ups, for example, wall sits, very nothing too aggressive. In terms of supportive therapy, we often have people see occupational therapy and also go for bracing. For example, that foot drop issue I talked about, bracing can help to stabilize the ankle at sort of a 90-degree angle so that you're not tripping on your feet. It makes walking easier. And then I often will direct patients to the different very, very helpful and wonderful societies that we have access to, including FSH Canada and Muscular Dystrophy Canada as well, which can be immensely supportive and helpful for patients for a variety of reasons. And part of it is, I'm going to just touch on this now. So there have been some interesting data and interesting research that has been done. Most of the time in medicine, we focus so much on the physical aspect. Here's the way that FSH presents, but we forget about how it actually impacts the individual. And so there was a recent article about the lived experience, and they talked about these different issues that come up that I think we could do a better job of addressing. What is it like for the life as the symptom progresses? So we forget a bit about the fatigue and some of those other things. And what they showed was that despite the difficulties that patients with FSHD have, overall their quality of life was decent because they were positive about the future, and they felt that a good quality of life was positive with support. They talk about the emotional journey, including the impact on mood, the sense of relief at having a diagnosis, but also the stress that comes with knowing that you have this condition for which currently there isn't any reversible treatment, but hope coming down the line. The impact on caregivers. And I alluded this a little bit with the facial weakness, but the impact of these things on nonverbal communication, for instance, which is really, really an important part of how we interact with others, right? If your smile is not, looking like other people, they might interpret that differently. So these can be very, very challenging for folks. And then this idea of visibility versus invisibility. Some people want their diagnosis known, other people don't want their diagnosis known, and that's an individual preference. And you can imagine if you don't share your diagnosis, but you have these issues, it might make it challenging sometimes for social connections, might lead to stigma and bias. And even among healthcare professionals, this is still a relatively rare disease that people might not know that much about. So just to switch gears slightly to talk about neuromuscular care in Toronto. So we have multiple academic centers in Toronto that see patients with neuromuscular diseases, but also lots of community neurologists who also share in the care of patients with a variety of genetic muscle diseases. We have access to physiotherapy and occupational therapy, and we refer to specialists as needed. But one of the things that I think we're missing is a multidisciplinary care approach or location that patients can go to receive sort of more holistic care, but also expertise in some of the rehabilitation and exercise elements for patients with muscle diseases itself. We don't really have that specific type of management aspect, at least at my institution. And so when you're thinking about that journey for patients with FSHD, it takes a while, right? They might see their doctor first. They might then get to see a neurologist or another specialist and have to have genetic testing done, which does go to CHIO, at least for FSHD1. And then once the diagnosis is made, by that point, there's also been a large other aspect of the journey, including counseling and genetic counseling and screening of family members, perhaps, supportive management, and then the participation in clinical trials. So I've been sending some patients to Dr. Lockmuller's lab in Ottawa as well, and they've been very grateful for the ability to participate in those trials. So I'm going to stop there. Just some take-home points, as everybody here knows. I think FSH does have that characteristic pattern of weakness, though not present in everybody, that can lead to some difficulties with diagnosis. And then the management does include a variety of aspects that we have to consider, not just clinical trials and things, but the supportive management and an increased awareness now of the emotional and other social impacts of the disease on the individual. So thank you very much for inviting me again.
So we want to take a couple questions.
Yes.
We have 2 minutes for questions for Dr. Kassardjian. Anyone with a question?
I do.
Oh, Neil.
Oh, sorry, this is right here.
He gets to go first.
Yeah.
Yeah.
I find that I'm wobbly. What I mean by that is that I have to be very careful how I walk and what I'm walking on, that sort of thing.
You want to start over real quick? I forgot about this.
Oh.
And hold it real close to your mouth. It's on.
Hello?
Yeah, there you go.
I have a wobbly issue. And,
Yeah.
I'm just wondering, you mentioned testing hearing and that sort of thing. I think my hearing's fine, but would an inner ear issue versus a muscle issue be more? Can you look at those things and determine whether my wobbliness is muscle or inner ear?
Yeah, that's a good question. I mean, I think there's a few different ways to look at it. I think the first thing with the wobbliness, it can be due to muscle weakness. Both muscle weakness up higher, which we often think about that as a hip issue, but if folks have weakness of the ankle muscles, like that difficulty bringing the foot up, the muscles around the ankle that bring your foot up and down stabilize your ankle. So if you have weakness of those muscles, your feet can be unstable, and that will lead to wobbliness or imbalance or a sensation of lack of balance for sure. So having said that as well, inner ear issues can also lead to problems with balance. And then as people get older, we start to have multiple things happening at once. So I think that the first thing I would say is that it would probably be rare for it to be any single one thing. So it's probably more than one thing that's contributing to that wobbly feeling. And so addressing each one will help to some degree, but it won't solve the entire problem. So it's probably a combination of more than one thing, actually. And people can have hearing loss and inner ear problems that are what we call subclinical. In other words, you may not notice them. Your wife may notice them, but you might not notice them, but they still might be there to a subtle degree.